Okay, so welcome to chapter 3, Understanding Residents. And in this chapter, we're going to start off by discussing residents' basic human needs, actually for all of us. And then we're going to end this chapter with talking about some of the mental health needs, as well as needs for those who are experiencing death or dying. Okay, so here are some terms to become familiar with. The first one is psychological needs. What are psychological needs? Those are needs that relate to the processes and activities that keep living things alive. Or physiological needs, I should say. I always get that mixed up. Physiological needs. In other words, these are needs that keeps us alive. These are the things that we need. Psychosocial needs are needs that involve social interactions, emotions, intellect, and also spirituality. So what I've learned is that we all may be different. We all may have different backgrounds, different culture, but we all have the same thing in common. We all have basic human needs. And that's where I want to kind of camp out today, is understanding basic human needs. And so there are basic physical needs of human beings. First of all, we need food and water. We need protection and shelter. We need activity. We need sleep and rest. We need comfort and freedom from pain. And how I look at this as being something important, I always think about this. What happens if I never get food? And what happens if I never get water, right? We know that we can't survive like that. Or then I think about what if I don't have the protection I need to keep me from any type of hurt, harm, or danger? Or what if I didn't have shelter and we know that it's 5 below outside and when we're living outside, what can potentially happen to us? So that's what makes basic needs important. Or we begin to look at things like, what if I never had activity? What if I never got up and got moving? Or, what if I always just sat here? What will happen? Okay. Eventually that can lead to death, because inactivity, being bedbound or just lying in a bed, can cause us to develop blood clots. It can cause us to develop pneumonia. Infection can set in, and that can eventually lead to death. Even the same with sleep and rest. I don't know if any of you've ever experienced lack of sleep, lack of rest, but what happens when you don't get that? Okay. And then what happens when you're constantly suffering from any type of pain? Okay. So just keep those things in mind. Now, the next thing that we see here is, how can you, as a nursing assistant, help address some of these physical needs in with your residents? And so I want you to go back to chapter 1 when we talked about ADLs, and that is our activities of daily living. Okay. So like we said, basic needs, we have to eat, we have to have food and water. And so you're going to assist your resident with eating. We said elimination. What happens if we never went to the bathroom? What happens, if we never eliminated our bowels or we never eliminated our urine? That stuff just kind of builds up in us. And so part of your role is to help assist your resident with those elimination needs. You're going to assist them with bathing, because what we see on this Maslow chart, you probably see this little pyramid in your book, self-esteem, all of that is on there. That's important. And so bathing and grooming will kind of help meet those needs, okay? But there's also psychosocial needs of human beings. Everybody wants to feel some sense of love and affection, whether we're experiencing love and affection from another human being. I even noticed that some people like to feel love and affection even from their pets, but you want to experience some type of love and affection. And that's the same thing with your residents. Your residents are in need of that love and affection. And the sad part is, some of our residents that's in these long-term care facilities for a long period of time, they may not have family to provide that love and affection. And so they look for that in us, okay? All of us want to feel acceptance by others. We want to feel like, that you're going to welcome us into this place. You want to feel accepted. Safety and security. Everyone wants to feel safe, no matter where you are. If you're in your classroom or you're on your job, even in your home, you want to feel that safety. You want to know that you're going to protect me from harm. You're not going to allow anything to happen to me. Everybody wants to feel that sense of self-reliance or independence in daily living. And that's one of the things that a lot of our elderly residents may lose out on. And that's feeling independent, because they feel like things have been snatched away from them. Their independence have been snatched away. Their health have been snatched away. They've experienced some form of a loss. And so those things are snatched away. And so now they feel like I have to depend on others. Also, some of those other psychosocial needs of human beings is just simply having contact with others, the outside world. They just want to know that, my family still loves me. I can, call and check on my grandkids, but also feeling successful. Everybody wants to feel like they are succeeding in something. And that also helps with boosting that self-esteem. So when a person's psychosocial needs, those are all the needs I just talked about, when those needs are not met, the response could be different, okay? And the response may include frustration. It can also include stress. It can also include fear, anxiety, anger. So if you ever wonder why, your residents are aggressive, why they are withdrawing, why they're stressing, they're frustrated, that is because the psychosocial needs are not met. So I want you to keep that in mind. When those needs are not met, these are what your residents, this is what they may experience, okay? All right, so once again, looking in your book, you'll see this chart called Maslow's hierarchy of needs. And so basically what this talks about is just ranking our needs in order of how we need them, right? At the bottom, even though it's at the bottom means that's the most important. And so our physiological needs, our oxygen, our water, our food, elimination, these are all important needs, okay? This is the only way we can survive. And so he's ranking them. Maslow is a psychologist. He's ranking these needs in order of how we need them, All right. And so 1 second here. I'm just muting everybody's video for our recording here. So it's okay, It's just strictly for our recording. Okay. He's also telling us that safety and security is the next thing that's considered important. Priority is physiological, but the next is safety and security, meaning that we have shelter, we have clothing, we have protection from harm, we are stable, we have a sense of stability, we know that we have a place to live. That's what that stability is all about. Then Maslow talks about the need for love. That's the next thing that's important to us, that feeling loved, feeling accepted, but also having that need for self-esteem. That's the achievement or the belief in one's own worth or value. But lastly, that need for self-actualization. That's the need to learn, create, and realize one's own potential. We all want to have that. Okay. So now we're going to get into some of the other needs we have. And so one of those needs is sexual needs. And so I want you to remember this. Respect and privacy are very important when encountering any sexual situation. I want you to remember that. Now, we've already talked about in chapter 1 the sexual abuse and things like that. And you already know that if we have one resident who's consenting and one who's non-consenting that's caught in a sexual act, then we know that's considered sexual abuse, okay? But just like basic needs, just like physiological needs, just like psychosocial needs, human beings have sexual needs. Just because you are 65 years and up, that does not mean that your sexual desires go away. That's not what that means, okay? They still have those needs. And so it is important for nursing assistants to remember the following about residents' sexual needs and sexual situations. The first term that you saw was what we call masturbation. And you can see that right now in your book. And so why bring that up? Masturbation is the satisfying of oneself. And so you may encounter, I have to bring this up, you may encounter a situation like that, okay? And if you encounter a situation like that, then we have to make sure that we act in a professional manner, okay? So I'm going to give you some pointers on that, but let me just go through this part here. When you come into these situations, first of all, you must understand that people continue to have sexual needs throughout their lives. That doesn't go away. Even the confused person, that doesn't go away, okay? Humans express their sexuality through different behaviors. Some people may be very vocal about how they're feeling, okay? Some people may like to touch to display what they are feeling, okay? And so just know that it's expressed in different behaviors, and that's why we brought up masturbation, because again, that is a way that they're expressing their sexuality or what they're feeling. So this is why we say knock and wait for a response before entering a resident's room. Always provide privacy if you encounter a sexual situation. But again, I have to always specify this. If you know you have two people that is consenting to this sexual act, yeah, then we would provide privacy. But if this is one person who is not consenting and one who's able to consent, that is a possibility of sexual abuse. So that has to be stopped. Our nurse has to be notified, and we have to intervene right away. You don't want to be, judgmental when it comes to this. Your book says to be open. You may have residents that may want to talk about this, okay? And that's just our time to be good listeners when it comes to that. We always respect residents' sexual orientation and also their gender identity. That is the world in which we live in now. So we have to make sure we respect that. Any type of, if there's a situation where you're working with a resident who is transgendered, you got to make sure we're calling them by their preferred name. That is something that we have to honor and respect. It is also important to remember the following about sexual needs and situations. There are often times that we may put up a sign that says, do not disturb. Okay, we have to honor that because again, residents have that right to express themselves sexually, especially if they are consenting. Okay, and both consenting adults. And remember, we do not view expressions of sexuality by the elderly as, oh, that's so cute, or, that is just disgusting, okay? We don't look at it that way. We act in a professional manner when we come across those type of situations. So these are just some myths about older adults and their sexuality. The first myth tells us that older men, and this is not in your book, but older men are not capable of having sexual relations. There are some physical changes that may alter the way a couple engages sexually, but however, men do continue to have satisfying relations well into their old age. Myth number 2, after menopause, women are not interested in sexual relations. And if you don't know, we'll learn it in chapter 4, but menopause is when women will stop having periods. And so although the body goes through some changes, and it kind of talks about some of those changes, again, it doesn't stop the desire to want to engage in those type of relations or behaviors. And then myth number 3, any expressions of sexuality by older people is disgusting or cute. This attitude deprives older people of their right to dignity and respect. Older adults have the same needs and rights to express their sexuality as any other age group. Okay, so we don't want to joke about it or anything like that. But again, we respect their privacy and however they want to express themselves. Okay. So remember, residents must be protected from unwanted sexual advances. If a nursing assistant sees sexual abuse happening, you should remove that resident from the situation right away, take them to a safe place, notify your nurse immediately if that happens. All right, so we've already talked about basic needs. We've talked about sexual needs. Now let's talk about spiritual needs, okay? Everybody will have some type of spiritual need. And so how can you help residents meet their spiritual needs? And you can do this by, number 1, learn about their religions or beliefs, okay? Doesn't mean that you are changing your religion or that you are changing your belief, but get to know about other religions and beliefs. It makes you a better caregiver. I am a born again Christian. I know who I am. I know who I belong to. However, I took a religion course because I take care of so many different people. And even in class, I meet so many different people. So I always like to know, learn, and understand other religions and other beliefs, so I can better also respect my residents when they are engaging in their religious practices. Also, we can respect residents' decision to participate in or to refrain from food-related rituals. There are some cultures and even some of those spiritual rituals that make us refrain from certain foods to eat. Okay, so again, we must respect that. We can encourage participation in religious services for residents who are religious. Every facility, even a hospital, will have a chapel, okay? Or nursing homes will have a clergy, a priest, or someone on staff. And so we encourage that, to participate in those religious services. Also, we must respect all religious items. What type of items am I talking about? I'm talking about Bibles, medallions, rosaries, prayer cloths. I have a prayer cloth that I will literally scream if my children get a hold to it. But those are religious items. They're very sacred to some people. So we have to make sure that we respect that, okay? Report any request to see a clergy. Report that to a nurse. Allow privacy for clergy visits. If asked, you may have to read religious materials out loud. And then also you can refer residents to spiritual resources if requested. Okay. Now, these are the things that's not permitted when it comes to nursing assistants dealing with our religions and beliefs. And this is what I always tell people. There's 2 topics that we never want to get into a debate about, and that is religion and politics. We always want to steer clear of that because that can get a person pretty fired up, depending on how the discussion or topic goes. But never try to change someone's religion. Okay, your job is not to be there to force your religion on anybody. Never tell a resident that their belief or their religion is wrong. Never express judgments about a religious group. Never insist that residents join religious activities. Again, they have a choice. Never interfere with religious practices. I took care of a priest one time, and I was so scared to go in his room. I'm like, oh my goodness, I feel like I'm walking into holy ground here, but he had his members from his church would come and actually have a mass in his room. And so we wouldn't interfere. I would give his medications around the time before it happens. And then we would just allow them to practice whatever they need to do during that time. Never discuss your beliefs, your personal beliefs or opinions, either directly or indirectly. Again, when it comes to, discussing religions and even with politics. This is just a great opportunity for us to be listeners. Okay. All right. Next, your book talks a little bit about holistic care. Holistic care is a type of care that involves caring for the whole person, which is the mind, as well as the entire body, the spirit, and all of that. Okay. So again, you may have some people that's really into holistic care. All right, so now let's talk a little bit about why promoting independence and self-care is so important, okay? Residents in long-term care facilities may be experiencing losses. And so this is why it's important for us to promote this independence. And so what type of losses are they experiencing? Some may experience loss of a spouse, loss of family or friends. Remember, they're moving from their home and they're moving into this facility where they're all alone. So again, loss of family or friends, but even loss of a spouse. A spouse could have died, or the spouse could be, independent and able to remain and live on their own, but then, the other spouse may be in a nursing home. So that's how they begin to experience these losses. Loss of workplace and even relationships. I remember I had a resident I took care of. She would often have crying spells, and, a lot of us couldn't understand why is she having a lot of these crying spells. And so one day I asked her, I said, Vivian, why are you having, cry? Are you in pain? And I would ask these questions and she told me no. And she actually showed me a picture of some little kids. And I says, who are these children? And, so cute. She says, those are my neighbors from my apartment. And she says, I miss them so much. They would always come to visit me. And they were little kids. She said they would come next door. They would come and visit me. And she said, I just miss it so much. And so they're experiencing a lot of loss when they come into these facilities. They may even experience loss of the ability to go places, to be free to drive any place they want to. Loss of the ability to attend services, meetings at their faith communities. And that's why we bring a lot of that stuff into the nursing facilities and even into hospitals. Loss of home and personal possessions, loss of health and ability to care for themselves, and even the loss of ability to move freely. So these are a lot of things and a lot of losses that they are experiencing. Okay. All right. Now, loss of independence can also cause some problems here. Loss of independence can cause poor self-image. It can cause anger. Okay. Imagine if I just snatched your keys and said, you can't drive anymore. You have to stay in this place for several weeks, And so a lot of them feel angry because of that. Some of them have feelings of helplessness, of sadness, of hopelessness. Some of them feel like I'm just not even useful anymore. They may even develop increased dependence because of that. Or depression can set in as a result of that. And so what we are to do as nursing assistants to kind of help combat some of those problems and feelings, we are to promote independence in our residents. You always want to promote independence. And how do we do that? We encourage our residents to do as much as possible for themselves, no matter how long it takes. If you know it takes a lot of time to accomplish a task, it's okay. Allow them that time, but you want to encourage them to do as much for themselves as possible. Be patient with them. Allow the residents to make those choices. Remember, it is important that nursing assistants never treat residents like children. Residents are adults who can make their own choices and should care for themselves as independently as possible. All right. So now let's look at the cultural differences. We're going to be taking care of a lot of people who have cultural differences. And so I want us to identify some ways to accommodate these cultural differences. And so here we have a couple terms. And again, I'll always let you know what to highlight. The first one is cultural diversity, which is the different groups of people with varied backgrounds and experiences who live together in one world or in the world. Bias is like a form of being prejudiced. Race is grouping of people based on physical characteristics shared by people with common ancestry. And then we have the term ethnicity, which is one aspect of a person's identity, often reflecting a combination of race, culture, language, nationality, and other factors. And so we need to understand that culture plays a part in determining all of the following. Our culture plays a part in how we speak, our language. It plays a part in our religion, who we believe in and what we practice. Our culture also plays a role in what we choose to eat, our food preferences, but also it plays a role when it comes to touch. And so what does that mean? Sometimes in healthcare, we try to be compassionate. Remember, we kind of talked about in chapter 1, some of those qualities of a good CNA, and one of them was being compassionate. And we try to be compassionate by either holding someone's hand or maybe giving them a back rub, just let them know everything is okay. But what we have to understand is, every culture does not accept touch like that. Okay, so you have to take those things into consideration when you touch people. Okay. Now, these next several slides just kind of talks about the different religious groups and some of the dietary practices that they engage in. So we're gonna get right on through that. We're not going to spend any time on that. Let me just keep going here. Okay, so remember, nursing assistants should focus on compassionate, respectful, and culturally sensitive care. They should treat residents as the residents wish to be treated, not as the nursing assistant wants to be treated. This is part of that person-centered care. Okay, so the next section in your book now talks about the need for activity. So I want you to remember, we're still on the Maslow pyramid chart. And one of the things that we talked about with the physiological and psychosocial needs is activity. And so physical activity has the following positive effects. When you're able to get up and get moving, it lessens your risk of illnesses. It relieves any type of symptoms of depression that you may have. It improves mood and concentration. It improves body function. Getting or staying active lowers your risk of any type of falls. It improves your sleep. It improves ability to cope with stress. It increases your energy, and it also increases your appetite. So just think about when you get up and go to the gym, you may, spend 30 minutes on a treadmill. How do you feel afterwards when you do that? That's what activity does for you. Now, inactivity can cause the following problems. And this is why it's important to not only encourage residents to be as independent as possible, but to encourage them the importance of getting up and getting moving. So inactivity can cause loss of self-esteem. It can cause anxiety. It can cause depression, boredom. I talked about this as well in chapter 1, that pneumonia can set in. Urinary tract infections can set in. Skin breakdown and pressure ulcers. Remember, we said that's a form of neglect that can set in. Constipation, when you don't move around a lot, constipation can set in, as well as blood clots or just feeling dull and sad. All of this is due to inactivity. So this is why it's important to get your residents up and moving. Now, part 6 in this chapter discusses the family roles and their significance in healthcare. We talked about the care team, and we did say on the care team, the resident being the most important person, but also the significant others or the family is on the care team. And we said, well, why is that? Because we know that family is so important to us. And so there are many different types, different family types. I'll let you look at this in your book. You can look at the description on your own. There is a little section in your worksheets that will kind of help you define the different family roles, but you have nuclear families, you have single parent families, you have married or committed couples, either of the same sex or opposite sex family. You have extended families as well as blended families. And so families may participate in the care of residents in these ways: by helping them to make care decisions, by communicating with the care team on the resident's behalf, by giving support and encouragement, connecting them to the outside world, and then also giving assurance to a resident who may be dying. It's important for the family to be involved in that. And so remember, resident families are likely experiencing significant adjustments as well. So nursing assistants should be respectful. They should allow privacy for visits and observe and report the effect of visits on the residents. And also remember that nursing assistants should take the time to ask families questions. It's good to kind of communicate with families. And you should communicate with families to show them that you have time for them, to show them that you are very involved in the residents' care. Okay. All right, we're going to move to the next section here, which just a little bit of psychology 101. But this next section and I'm not going to spend a lot of time on it, but it just describes the stages of human growth and development. And so you'll see a term here. It's going to come up again later on, but it's called cognitive. And cognitive is related to being able to think and learn on your own. So what are the stages of growth and development? We know that when we're born, we first go through the stage of infancy, which is birth to 12 months. And in this stage, we grow, we develop quickly. Our development is usually from the head down at this point. And then we move from infancy to what we call toddlerhood. And that's usually from ages 1 to 3. And so that's when we're formally dependent. We're gaining independence and some body control. We're learning how to speak. I don't know if any of you take care of anybody in this age group, but learning how to speak, learning how to gain coordination, learning how to use the bathroom and control the bowel and bladder. They may experience some tantrums. They may whine to get their way. And I want you to just remember this, because a lot of these behaviors begin to come back as we get into the elderly years. So just kind of keep in mind what some of these behaviors that we're talking about. Then the next growth development stage is the preschool years. And that's usually from ages 3 to 5. And we know they're beginning to form relationships. They can play cooperative, they can learn language. And at this age, we hope that they would know the right from wrong. Then we have those school age years, right? These are the fun age. They have cognitive development. That's that term, cognitive. They're learning how to really think and really learn things. I say they're like sponges at this point. They just soak up everything. They learn to get along with others in their peer groups. They learn to develop a conscious and even self-esteem. Then we move to the next years, which we call the pre-adolescent years. That's ages 10 to 12. And so those years, you're growing now a sense of identity. You're becoming the person who you are designed to be. Strong identity with peers, relatively calm period. Usually imaginary fears will give way to fears based on the real world. So reality now begins to set in. Then we move to the adolescent years. And even some of us on this line could be part of this adolescent years from ages 12 to 18. That's your onset of puberty. Your sex characteristics are really coming in now. Your reproductive organs are beginning to function. Now we know this is the age group where we're really concerned about body image and being accepted. And again, that's that chart. We talk about acceptance. And then even in this age group, we see that the moods are now beginning to change. And then we move from adolescent to now the young adulthood. And young adulthood is those ages from 18 to 40. That's probably the majority of us on this line. But at this stage, we're selecting an education, we're selecting a career. We select a mate. We may even begin to raise children at this age. We may develop a satisfying sex life. And then we move to middle adulthood, which is our age group of 40 to 65. We're more comfortable and we are stable at this point. Physical changes. This is where we're headed to. Physical changes related to aging begins to occur. And we're going to talk a lot about that in chapter 4. So I want you to really, you can circle this and say, this is the focus for nurse aid training. The physical changes related to aging will begin to occur. And then we get into late adulthood, which is 65 years and older. And so at this point, many physical and psychosocial changes begin to occur. We begin to see the change in our skin, the change in our hair, the change in our body structure, all of this. That's our physical health. We may begin to experience losses of friends and jobs during this age group. And so that's when ageism sets in, or we'll say the aging process. But ageism is just a prejudice towards or stereotyping or discriminating against the older people, saying things like, you're 65 years old, or you're old, so you never can do this, you can't do this, or you won't be able to do that. And that's not true. In fact, people over 80 years of old cannot live by themselves. That's not true. These are all of these different type of myths that come up. I can tell you, I used to work at an assisted living, and every morning I would drive onto campus. I would see 90-year-olds, even some that's well into their 90s, living by themselves. Some of them are still out jogging and just enjoying life. Most older adults are lonely and depressed. That is not true. In fact, the older you get, because you're more stable, you begin to enjoy life more. Older adults are not able to adjust to change. Could be true in some factors, especially if we're moving from a home to a nursing home. We have a lot of fears because remember, we talked about the losses. So they may have a little bit of a hard time adjusting. I'm not going to say they're not able to adjust, but they may have a hard time adjusting. Most older adults are ill or disabled in some way. Not always true. There are older adults that are very healthy. I've met some that may not even be taking medication. So again, we don't want to say that, most of them are, but they may experience some type of ailment at some point. Older adults can stay active by pursuing favorite hobbies. Yes, that is true. The more they stay active, by being a part of groups and things like that, that keeps them active. Number 6, good health can help older adults live independently. Absolutely. And then number 7, normal changes of aging do not include disease, disabilities, or dependence on others. And again, that is true. We're going to go over some of those normal changes of aging. So here are some facts to remember about aging. Older adults have different capabilities. Stereotypes are false. Older persons are usually active. Aging is a normal process. It is not a disease. It's normal for us to get older. Aging persons need to adjust to change, and they do not need to be dependent. Again, we're going to encourage independence. So what are some of the normal changes? Now, we're going to really dig into this in chapter 4, but I wanted to just spend a little time on what normal changes of aging will include. And so you'll notice that your hair becomes very thin. Skin and hair becomes thin, drier, more fragile. Our muscles are weaker. Our bones become more brittle, which is putting us more at risk for fractures. We have a slower response. Our memory may go. Our heart may not work as strong as it used to. We may not have a big appetite like we used to. We may have frequent urinary elimination. We may deal a lot more with constipation. We're going to learn in chapter 4 that our hormone levels begin to change. Our immune system will become weakened, making us more prone to infection. And it's just an overall life change that we may experience. But remember that the following are not considered normal changes of aging. Any type of depression, any type of suicidal thoughts, unable to think logically, poor nutrition, shortness of breath. These are all considered abnormal. This is not a normal sign of that you're aging. Okay, these are not normal changes. So let's shift a little bit from growth and development. And let's now begin to discuss some of the developmental disabilities, because now we're getting into a little bit more of the type of people that we're going to be taking care of. Developmental disabilities are disabilities that are present at birth or emerge during childhood that restrict physical and or mental ability. And the following are important points about intellectual disability. Now, this is not a disease or a psychiatric illness. This just means that they may have below average mental functioning. So it could be someone who may be possibly autistic, someone who may have Down syndrome. They may have limited ability to live independently. They may have the same emotional and physical needs as others. Okay. But nursing assistants should remember the following when caring for residents with an intellectual disability, including meeting emotional and physical needs. Always treat them as an adult, okay? Praise and encourage us. Often you'll see these guidelines in your book. Help teach your the activities of daily living by dividing up the tasks and giving them smaller things to do. Promote independence, no matter what, always promote independence. Encourage social interaction. Repeat words if you have to make sure that they understand. But I want to make sure you see this part. You have to be patient. And that's with any group of people you're working with in healthcare. You have to be patient. Now I'm going to shift from developmental disabilities and talk a little bit about some of the mental health disorders that you may encounter in a healthcare setting. All right, depression. Depression is a type of mood disorder that causes pain, fatigue, apathy. What is apathy? Next term, apathy is a lack of interest in activities. It could be sadness, anxiety. People who are depressed oftentimes will have a hard time going to sleep. They may even lose their appetite as well as other symptoms. Depression, you may also know it as depressive disorder or clinical depression. And so what I tell people is know the signs and symptoms of depression. That's important. Know the signs and symptoms of depression. And we just talked about these people may be tired all the time. They don't want to be bothered. They don't want to eat. They may begin to refuse a lot of things. They may refuse medications and stuff like that. You know, they may tell you, I don't want to get out of bed. You know, these type of things you have to report back to your nurse, because what we worry about is suicidal thoughts, okay? Wanting to give up. And sometimes a lot of people may not come out and actively say, I want to end my life, but they can do what I call passive suicide, where they may refuse medication because you know over time what refusing medication will do, okay? Another type of disorder is a bipolar disorder. You may take care of someone who has that. That is a mental health disorder that causes a person to swing from periods of deep depression, which we call a depressive episode, to periods of extreme activity, which we call a manic episode. Manic episode, okay? So again, we're just talking about different signs and symptoms so you'll know how to recognize these things and when to report. Other type of mental health disorders that you may encounter is what we call anxiety. Anxiety is uneasiness or worry or fear, often about a situation or a condition. So sometimes you know what causes you to be anxious. Another type of anxiety disorder is what we call generalized anxiety disorder. That is an anxiety disorder that is characterized by anxiety and worry, even when there's no cause for the feelings. why am I, having anxiety? I don't know, that's actually a disorder. Some people have what we call panic disorder. That's a disorder characterized by a person having regular panic attacks or living with constant anxiety about having another attack. Panic attacks, can come in different ways. You'll see a person who, maybe breathing hard or pacing the floors or things like that. Those are all signs of a possible panic attack. Some people have social anxiety disorder. That's a disorder in which a person has excessive anxiety about social situations, getting out into the dining room and eating with people. Some people may have that social anxiety. Other forms of anxiety can come in the form of a phobia. That's an intense, irrational fear of or anxiety about an object, a place, or a situation. So you may have some people that says, I have claustrophobia, where they have this fear of being enclosed into tight spaces. So again, that is a form of anxiety. Another type of form of anxiety is what we call obsessive compulsive disorder. Some of you may know it as OCD. That is an anxiety disorder that's characterized by obsessive behavior or thoughts, which may cause the person to repeatedly perform a behavior or a routine. And then you may have something called PTSD, what we know as post-traumatic stress disorder. This, again, is an anxiety disorder caused by experiencing or witnessing a traumatic experience. And I'll give you an example of that. Usually during the 4th of July, our residents tend to have a harder time, those especially who have fought in wars or what have you. When those fireworks go off, that noise, that definitely can cause a panic, okay? And that's a form of that post-traumatic stress disorder. Okay, let's keep going here. All right, and then lastly here, we have a disorder called schizophrenia, which you may know, but it is a type of psychotic disorder. It is a type of psychotic disorder that causes problems with thinking, it causes problems with reasoning, and it causes problems with communication and the ability to manage their emotions. It causes problems with that as well. They have, hallucinations, which is a false belief, I should say, or persistent false beliefs. They also can have delusions, again, which is persistent false beliefs. People who have a history of schizophrenic and schizophrenic type behaviors have to go through what we call psychotherapy or some type of behavior therapy to really help them cope with reality. So dealing with all of this, what is your role? Nursing assistants should remember the following when you are taking care of those who have a mental health disorder. Always observe your resident for any changes in their behavior, whether it's an increase in behavior or a decrease in something. You want to be able to document and report that. Support the resident and their family and friends. Encourage residents, again, to do as much as possible for themselves. And keep in mind that mental health disorders can be treated, okay? When caring for residents with a mental illness, it's very important to know their changes in their ability. Sometimes they can't do certain things. Their changes, their positive or negative mood changes, behavior changes, any type of comments about hurting themselves, even if they're joking. These are things that need to be reported right away. Failure to take medicine, because again, they know over time what that can do. That can trigger a lot of their mental illness behaviors. Even if they have real or imagined, physical symptoms reported. Some people who deal with a lot of depression, they may say, I'm having headaches and stomach aches all the time, and they may not be. It could just be the depression manifesting in different ways. Again, you have to report that. Report any type of events, situations, or anything that can provoke a reaction. And remember this, intellectual disability and mental health disorders are not the same. okay? Although they are different conditions, persons who have either condition need emotional support at all times, as well as care and treatment. All right, as we begin to close out this chapter, because we are nearing to the end, I want to just have a brief discussions on how to care for residents who are dying. Okay, so we got about 10 more minutes left here. Who are dying? And so here's a couple terms to understand. Terminal illness, which we've already talked about, we know that is a condition that will eventually cause death. But I also want you to understand what grief means. Grief is a deep distress or sorrow over a loss. And so what happens is people who experience losses, it doesn't always have to be a physical death, but it can just be any type of loss. It can be a relationship, loss of a relationship, loss of a friend, a pet, a job, anything like that. When you experience a loss, there is a psychologist by the name of Dr. Elizabeth Kubler-Ross who describes these 5 stages. I call it 5 stages of grief. She calls it 5 stages of dying. But sometimes this is the grieving process that people go through when they experience a loss. And so I want you to highlight this in your book so you can understand the different stages that people go through when they experience loss or from dying or getting ready to make that transition to die. People go through these different stages. One thing to understand is everybody will not go through the same stages at one time. They won't flow in the order that we're going to discuss them. Some people can experience one for 2 years and another one for 4 years and another one for 2 months. So it just varies person by person. The grieving process is an individual experience. Everybody is different on how they grieve and what they will experience. But denial, a person may be in denial. You may all of a sudden just have heard some terrible news or, have lost something. People go through a stage of denial where they refuse to believe that this could have occurred, or like your book says, they refuse to believe that they are now dying. Some people may experience anger about a certain situation, why me? And sometimes they take that anger out on staff, okay? And so remember, chapter 1, we talked about showing empathy, putting yourself in that situation. Okay, putting yourself in that situation. Then people may go through the bargaining, if I stop smoking or I stop doing this, making deals with God, making deals with the doctor, to get some relief here, or to, get them to, can you reevaluate me to see if this is something that is really happening? But some people may then begin to go through a period of depression, where they feel that they need to mourn. Then they begin to review their lives, and then they begin to look back, on relationships, or, you start reflecting on things, and that's what causes the depression to now begin to set in. But then with all losses and, with all the things that we deal with, at some point, we have to get to the point of acceptance. And that's either preparing for death, accepting the loss, or whatever the case may be, we get to the point of accepting it. And so remember, not every person dying goes through all these stages or goes through them in this order, or it doesn't always have to be a situation of dying. Now, when caring for residents who may have a terminal illness, who, we know at some point will be dying, I want you to understand the following terms. Advance directive. These, and I'll tell you which one I really want you to know. But an advance directive is a legal document that allows people to choose what medical care they wish to have if they are unable to make decisions for themselves. And we push for everybody to have an advance directive, because you may get into a hospital situation, you can have surgery, and your life can be changed forever, where you're unable to make decisions for yourself. So you want to designate this in advance. Living will is kind of similar to that. Durable power of attorney for healthcare. That is a witness document of, a witness legal document that appoints someone else to make medical decisions for a person in the event that they become unable to do so. Okay, so a lot of your residents who you'll be working with, they have a power, we call it a power of attorney for healthcare. Okay. Okay. Let's see. All right. Now, this one I do want you to highlight. It is called a do not resuscitate order. We call it DNR, do not resuscitate. And I want you to highlight this because first, let me tell you, it's a medical order that instructs medical professionals not to perform CPR in the event of a cardiac or respiratory arrest. And it is important for us to know that the residents that you're taking care of, you need to know who is a do not resuscitate, because all of you all at some point, you need to be CPR certified. And so when you're CPR certified, you have that right to be able to perform CPR, especially depending on where you work. So you just don't want to go perform a CPR on everybody, okay? Because some people may have a DNR. They may have a do not resuscitate order, which means that they don't want, any chest compressions. They don't want any type of life-sustaining measures to take place, okay? So when people have these advanced directives in place, we must honor them, no matter how you feel about it. Like I mentioned, I know of a person who's well in their 20s, only have not too much longer to live, but even with that, it's like, his decision is do not resuscitate me. Do not resuscitate me. And even though we look at it and says, yeah, but you're young and blah, 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 that's their wishes. And we have to honor that, okay? But I want you to understand that, working in this field, you're going to experience working with someone who is dying. That is something that you can't avoid. Getting into healthcare, you're going to experience it, whether it's with an older adult or even a child, you're going to experience it. And so all these factors can influence your feelings and attitudes about death. And so I used to try to avoid it when I first became a SENA. I didn't want to face it, but I think over the years, my experience with other people dying, close family members, definitely helped. Your book talks about your personality type, even your religious beliefs when it comes to death and dying, or your cultural background. All these different things can influence how you feel about death, okay? So that's a conversation to, have with yourself. What are you able to handle when it comes to this? Because this is definitely something that you're going to encounter when working in the healthcare field. So let's talk about now caring for the dying resident. What should you be aware of when somebody is dying? So diminished senses, what does that mean? We know your senses is hear, sight, touch, smell, taste. And so what happens is when a person is dying, they begin to lose some of their senses, okay? So we usually say, keep the lights low. But also we know that working with someone who is dying, hearing is the very last sense to go. And so being careful of things that's being said. A lot of times I tell family, listen, they may not can talk, they may not can move, but they can still hear. Okay, so being very careful with things that's being said to the resident. We're caring for the mouth and nose. A lot of this may not make sense right now, but once we get into chapter 6, when we talk about mouth care, it will begin to make sense. Even though they're dying, we're still giving, great skincare. We're still bathing them. We're still making sure their hygiene is good. We're still making sure their environment is clean. And we're providing as much emotional and spiritual support as possible, okay? All right, and it's also good to remember, you want your resident to die with dignity. Remember, they have rights, those same rights, resident rights that we talked about in chapter 2. Even when your resident is dying, they have rights, okay? So this is what you see here. They have the same rights. Okay. Now, let's look at signs that death is actually approaching. Signs that death is approaching. And so what your residents will begin to experience is blurred vision or failing vision, Their eyes may become unfocused. Their speech may become impaired. They may have a diminished sense of touch, loss of movement, loss of muscle tone, even a loss of feeling. Oftentimes when a resident is dying, their body temperature changes. They may have periods of having very high body temperature. So it looks like they have a fever, and then they'll have a below normal temperature. This is the body trying to adjust to this big transition that it's making. The body is failing, okay? They may have a decrease in blood pressure. When we meet in class, if we're going to learn how to take a pulse, and so you'll notice that their pulse becomes very weak, but it can be very slow or it can go very fast. Okay, again, it is a sign of the body making the transition. They may begin to have what we call Cheyne-Stokes, where their breathing, their respirations become very rapid and very, very shallow. You may hear the gurgling sound in their throat when they're breathing. A lot of times that's secretions. Their skin may be very pale, may feel very cold to touch. It may look blotchy, which is a sign of poor circulation. Again, the body is making the transition. They may sweat even though they're cold. Here's a term to become familiar with, but we're going to see it again, so don't worry. It's called incontinence. And your incontinence is loss of bodily, your urine in your bowels, okay? And again, we learn a lot more of that in chapter 4. The resident may appear to be disoriented or may even be confused, okay? So what happens after they've made the transition, okay? The resident has now passed away. And so at that point, we begin what we call postmortem care, which is care of the body after death, okay? What happens is a nurse RN or a doctor will come to pronounce the time of death. And then once that happens, that's when we begin the after death care or postmortem care. I highly encourage you, once you get out and start working, ask the questions, what is your policy on postmortem care? But this is what it looks like. So it tells you that rigor mortis begins to set in, I believe 2 to 6 hours. Look in your book because it does say it under that postmortem care when rigor mortis set in. You definitely want to highlight that part in your book that talks about rigor mortis. I have seen that on the state exam questions, okay? So you want to highlight that in your book. But rigor mortis may make the body difficult to move, very stiff, okay? So talk to your nurse because they're going to tell you, how to lay them flat and stuff like that, okay? You want to bathe the body gently, okay? Do not remove any tubes or equipment. We don't do anything like that. You may be instructed to put dentures in the mouth and to close their eyes, okay? You'll be, instructed on how to position the body. Again, it all goes according to facility policy when it comes to not only how you handle the body, but even the personal belongings of that person who has passed on. Now, nursing home looks different, okay? Nursing home, this is their home. So that body will remain there until the funeral home come and pick them up. Hospital looks different. In a hospital has a morgue, okay? So usually that body within 2 hours has to get down to the morgue, okay? So again, it all depends on your facility's policies when it comes to postmortem care. And that is something that you have to follow. Okay, so as I'm closing out, these are some questions to think about. How can you show emotional support to a resident who is dying or even to the families after death? And what I tell people, is evaluate your own self. Know that you're going to grieve too, because when you're working in long-term care, you're taking care of the same person all the time. So you're gonna grieve too, okay? Do you think it would be difficult for you to provide postmortem care? If you would have asked me this question 20 years ago when I first became a nurse, I would tell you absolutely, and I don't want to do it, but I think just having my partners, do this with me. That's why I say always check the policy, because sometimes it takes more than 2 people to do this. Once I did it a couple times, I think I was okay. It wasn't the best, but what made me able to do it, let me not say better, but what made me able is when I lost my father. And that's when I began to look at the death and the dying in a different way, because now it's like, I need to really be there for that family, because I remember how those doctors, I remember how those nurses and those caregivers, comforted us during that time. Even when they had to do postmortem care on my dad, I was right there. So that made me a better caregiver when I had my own personal experience with it. And so again, remember, you're going to grieve too when you're taking care of people that has passed on. You may be in shock. You may be in denial. You may go through all of these different feelings that we talked about earlier. And then also to hospice care, that is holistic, compassionate care. We talked about that, given to people who have 6 months or less to live. Some CNAs love to work in hospice. I have many caregivers that work in that area. That just may be something you're interested in. And then palliative care is care given to people who got a serious disease. They are dying, but we're just focusing on control of the symptoms. They may have more than 6 months, okay? Hospice care works to promote the comfort of the resident and dignity of the resident when they're making that transition. So again, if that's something that you want to get into, those are some of the qualities of being a hospice aide. Hospice care workers, they work to meet the physical, emotional, social, and spiritual needs of the resident as well, okay? And so what are some of those skills and attitudes in hospice? You got to be a good listener. You got to respect privacy and independence. You got to be sensitive to the needs. You got to watch your own feelings, because you don't want to be the one to slip into depression every time somebody dies. So you got to watch your own feelings. You got to be able to recognize stress. You got to take good care of yourself mentally and physically. Okay. You got to know when to take a break, but listen, you got to allow yourself time to grieve when you are working with those in hospice. Okay. And so again, think about these questions. Are the skills and attitudes necessary for hospice work any different from those required from any healthcare settings? It is no different. You got to know when to take time for yourself. Okay. And how can NAs deal with their own feelings when doing hospice work? Again, what are your cultural beliefs? What is your experience with the death and dying? How do you feel about that? If you have to take care of a body, what does all that mean to you? So again, it's always good for you to examine your own feelings when it comes to working with the death and dying. So this has concluded our lecture. We are an hour and 7 minutes into this, just a little bit over time, because I did say about an hour, 45 minutes to an hour. But this has concluded chapter 3 of our program.